if that is not enough, she's also passionate about education and advocacy on social media and is the host of the Interlude podcast. And last, but certainly not least, we have Janie Fielder. Janie is the medical science liaison at Natera Oncology with a focus on Signatera, providing support to providers in Georgia, North Carolina, and South Carolina. And before joining Natera, she was a nurse and nurse practitioner for many years. Welcome, everyone. I am so honored to have you all on stage with me today because you all have a wealth of knowledge, and I'm so excited to share this with everyone. So to start off, let's just talk about what's new and exciting, what is getting you really excited about what's coming forward. So I'm going to start with you, Eleonora. You're coming straight from ASCO, which is the American Society of Clinical Oncology's big conference of the year. This is where so much of the important news is shared. What are some highlights related to breast and gynecologic cancer?
Okay, that we can talk for hours about that, but thank you for having me here. So I was just at ASCO, which is really the biggest, were you there?
I wasn't there,
Okay.
I wasn't there.
All right, biggest kind of oncology meeting globally every year, and so there's lots of data presented, over 5,000 different studies, presentations, abstracts. You know, there are a couple of big takeaway points, and we can certainly touch on those later, but I think the big kind of theme that's happening is, one, in the metastatic space is really prolonging survival, improving options while trying to minimize toxicity and improve quality of life for patients. And then in early stage breast cancer, thinking about who really needs the aggressive treatment. You know, does everyone need chemotherapy and endocrine therapy and ovarian suppression for hormone receptor positive breast cancer? For patients who don't have a pathologic complete response for triple negative, can we escalate? Can we use new drugs? So really that personalized medicine approach. And similarly in gynecologic cancer, this is not a huge meeting for GYN cancers. They have a Society for GYN Oncology in March, but I think, again, similar ideas, novel drugs, new antibody drug conjugates. So we have trastuzumab deruxtecan, which is really big in breast, and there's some newer drugs coming also for both breast and GYN cancers in that space. So lots happening, but really, again, on that focus of personalized medicine.
Thank you so much. Over to you, Elizabeth. What are emerging techniques that you're excited about in breast reconstruction?
Okay, so gosh, I have to say though that the biggest thing emerging in breast reconstruction is patient-driven access, and I think that aside from like the techniques, the fact that patients know that they should have options and they are applying positive peer pressure to doctors is the biggest change that I have seen in 10 years. So I think patients demanding better and patients knowing that they deserve better is raising the tide for all of us. So to me, that's the biggest thing happening in breast recon.
Hell yeah. Dina, what's trending in genetics?
Yeah, so in cancer genetics, our technology is improving. Every year, there are new genes being researched, new genes being discovered, and there are technologies that are able to read more in between the genes that we couldn't do before to find disease-causing variants that we couldn't find before. And then there's something called polygenic risk scores. I don't know if any of you have heard of those PRS scores. Yeah? And those are, instead of looking at the single genes that cause high risk for disease, that are maybe less common, it's looking at some of the more common variations in our population that are individually small but can add up to give someone a higher risk. So it's really helping us understand what someone's risk is if they test negative on a genetic testing panel, and that's kind of the new wave, and I'm seeing it more commercially available too. So I think that that's going to be something big, and as we learn more and the algorithms get better, we can predict risk in people that before were kind of in a gray zone. Yeah.
That's really exciting. Janie, I would love to ask you about some of the research that you're seeing at Natera.
Absolutely. Can I first ask who in the audience has had a Signatera test? Okay, great. Has your provider ever said, I don't know what to do with a positive? So we are actively have studies going to answer that question. So a couple of studies in ER positive, also looking at escalation and de-escalation that Dr. Toplinsky mentioned. Who are the patients that need to be escalated to a CDK4/6 inhibitor, and who are the patients that can be spared that? So we also are in conversation about some studies that we would like to start. There's a large study going on in 10 countries in Europe looking at a drug called elacestrant and Signatera. And we are in conversations about a couple of different studies that we're hoping to open. One of them involves women of color. So why do more women of color have triple-negative breast cancer, and why is it so devastating? And how can Signatera play a part in helping those patients in their journey? So a lot going on.
Thank you so much. And Isaac, I know your lab focuses a lot on immunotherapy, so can you share a little bit about what's happening there?
Yeah, well, first of all, I just wanted to say thank you so much for inviting me to be part of your community. I mean, this is just incredible. Like the energy here, the people here, I'm just floored. And I've been taking video to take it back to my lab to show them that, you know, what they're doing the research for, who they're doing the research for.
That's awesome.
I'm just really stunned. You know, and I think it speaks to the leadership and all of you guys here and everyone participating, just, you know, the thirst for knowledge, trying to make sense of what's going on in your own journeys and those around you. So I think actually, you know, in terms of cancer research, it's been very, very exciting period in cancer research. I think you actually see a lot of industry and academic partnerships focus on trying to create new drugs. And so I think there's new classes of drugs, especially for breast cancer. I think antibody drug conjugates has been very exciting for the breast cancer space. But I think what we're also seeing in terms of immunotherapy is the ability to understand how our own bodies react, our own immune systems react to cancer. And I think that's something that, you know, our lab and other labs are very focused on, is trying to understand how we can reactivate our personal body's immune systems to fight cancer better. And I'm just very excited about the tools that we have available to do that. Whether it's from the biomarker perspective, can we detect, you know, what someone's immune system might be doing actively at this moment in time, or whether that's on the therapeutics. You know, can we create better immunotherapies that can help more women with breast cancer?
Thank you.
That's huge. Yeah.
And I think that's the perfect lead-in for the question that I have for Dina and for Janie, because I think often when we think about genetics, we often think about the variants like BRCA that give someone a predisposition to developing certain cancers, but we know that that's not it. There's so much more to genetics. So could the two of you give us a little bit of a genetic testing 101? What are the different types of tests? Who might be a candidate for different types? And what type of information does this give us?
You want me to start? Okay, so when we think of the word genetic testing, it can actually mean a lot of different things, and it's not just in the cancer space. As a genetic counselor, we're trained in all these different areas. But in cancer, there are kind of a few different categories of genetic testing. So the one that I specialize in is called germline genetic testing, and what that means is we are looking at the genes, the genetic code that you were born with, and that is in every cell in your body to see if there's any predisposition to developing a cancer, if there's a higher risk of your cells becoming a cancer. And so that is done usually with blood or saliva, because we're looking at the cells straight from the bone marrow, whereas there is the tumor test, which Janie will talk about, and some other testing too that you'll talk about. But with germline genetic testing, usually when you test once, your code doesn't change. So If you get tested with a panel of genes, that's not going to be different. The only thing that would be different would be if more genes were added to your panel, or the technology improved and was then able to detect some variants that were not previously detected. And the reason that germline genetic testing is used is typically, one, to understand why someone developed a cancer if they've already developed it, or two, to understand your risk for developing it and what you can do to get ahead of that risk. And then three, to help your family members too, because if you have a variant, a pathogenic variant or disease-causing variant, which we call a mutation, then your relatives will be at an increased risk as well, and it will give us more information about what cancers you might be at an increased risk for and what screening to do to try and mitigate some of that risk. So that's the germline genetics.
So there are a lot of different tests that fall under the umbrella of what I will use this big long word, comprehensive genomic profiling, or CGP. You will hear those terms. And so different from germline, these are mutations that you can develop. And these are mutations that there are different drugs and therapies that can be designed for that. And so this is usually done with tissue or blood, depending on which test that you utilize. And the results that you get back, if any of you have ever seen this, is that your report will tell you, are there specific drugs that can be used for the mutations that you have? And then also, are there any clinical trials that you could possibly be enrolled in looking at these different mutations and how they would respond to therapy? So different things, and they're always usually recommended if you have you present with metastatic cancer.
Thank you both. And over to you, Eleanor and Isaac. So Janie and Dina just shared that there's a lot of information that we can learn from these different types of testing, but how does that then translate into clinical practice? How does that information help you as a provider make decisions around what type of care someone would receive? And I know we mentioned a lot about de-escalation, so how can that information play a role in that, especially when it comes to quality of life?
Yeah, sure. So I think, kind of separating early stage and metastatic disease, and then, kind of thinking about GYN cancers as well. So everyone who has a gynecologic cancer, especially ovarian cancer, really everyone should be getting genetic testing. And for more advanced stages of ovarian cancer especially, we're testing both the germline and the tumor as well. In metastatic breast cancer, everyone at some point absolutely needs to get molecular profiling of their tumor and genetic testing. Sometimes that's not done immediately in the first line because it may not change the management, and sometimes we do it in the second line. There's new drugs that require us, for example, to look for an ESR1 mutation to see if you're a candidate for a drug called elacestrant, and that's a blood test that we can do. So it's all evolving. In early stage breast cancer, we're not routinely yet testing the tumor, but as more trials come out and more drugs come out, that will change. But what I do want to tell you is that ASCO back in January of this year said everyone who is 65 and younger should be getting genetic testing, germline, through their blood. And that's a huge change because talk about you have options, right? I mean, that's a huge change because before we weren't doing that, and people who didn't meet the, X amount of family members and didn't know their family history, were adopted, couldn't get genetic testing. And so that's a huge, huge thing. And if you're over 65 and it will impact your care, for example, for a PARP inhibitor, for a triple negative or hormone receptor positive, or if it will impact what your family members do, you're eligible as well. So really, we're testing everyone. And I think that's, again, knowledge is power.
Yeah, and I'll just add, I think that's actually really encompassing almost everything. But I'll just add that we started to think more about testing in the adjuvant setting, so this early stage setting where people kind of have early stage treatment, and then they might be high risk for recurrence. And I think there's studies that are coming out that utilize cell-free DNA that could be used to help understand your risk for recurrence. And maybe that leads to different types of monitoring. I think that the issue is that the studies haven't come out yet, and they require so many people to be enrolled in the trials. So those trials take a while to be able to run properly. And I think that's where the limitation is. On the metastatic side, I think I started doing it very early. I think there's different treatment options that can be changed by inherited germline information. And then I also started to see if we can track evolution of the tumor under treatment in any way. And I think my philosophy, or at least my clinical philosophy, has always been, if we can just understand a little bit more about what's going on in your body, that's not wasted knowledge. We might not be able to use it right away, but I just don't think it's wasted knowledge.
That's awesome.
That, I think, is such an important message, that any knowledge we can gain about what is happening, whether or not it can be used, is another thing in our toolkit. But on the topic of de-escalation again, I think a lot of breasties, and I can just speak from my own experience, that when you are facing a diagnosis, you feel like you want to throw everything at it to prevent a chance of recurrence. But Eleanor, as you mentioned at ASCO, there's conversations around de-escalation, so reducing the amount of treatment someone might need because of their specific profile. How do you talk to someone in your clinic about that?
I think you hit the nail on the head, right? It's hard where you want to do everything that you can, but it comes with toxicity and side effects. And so does everyone, and I kind of go through that, right? Does everyone need everything? And until we have clinical trials to answer that question, I always talk to patients, if we have a clinical trial that we can enroll people on, that's going to help us answer these questions. And sometimes we don't know, and sometimes it's really the conversation about, what are your goals? I will have people who say, I will do everything I can to keep this from coming back. And for me, I will, they'll say, I'll deal with the side effects. And other people say, I'm going to accept that higher risk, but my quality of life is worth it today to me. And so there's no right answer there. I think that's where it's a conversation. I was with a patient this week, and she said, I was telling her about chemotherapy, and she had a high oncotype. And she said to me, well, that's your world. This is not my world, even though I'm kind of in it now, but I can't wrap my head around what chemo will be. And so I think it's conversations. It's not a conversation that's answered in one day necessarily. I always tell people, you don't have to make a decision today. And I'll share, there's one trial that we're really excited about. It's called the Offset trial, which is looking at, does every premenopausal woman need, with certain criteria, but do they need endocrine therapy, ovarian suppression, and chemotherapy? Or if they have this intermediate oncotype, can we omit chemotherapy? And I think that's going to be really huge. So these are the types of questions that are looking at de-escalation, but it's hard because you don't know the answer, and you don't know, well, what is that trial going to show? So I'm always grateful for anyone who enrolls on a clinical trial, because that really brings the field forward. Can I ask a question? Has anyone been on a trial? Or, that's, yeah, that's huge. Yeah.
That's huge. Yeah, I wanted to, I think what you did just now was amazing, because these are the conversations that I think I have, and I think other medical oncologists have, and I think you guys, everyone should be thinking about is risk perception. And just, I think right now the risk, that faces you, for a lot of you, is that breast cancer is right here. But then I think there's a lot of other risk in the world, and how do you go about deciding, how do you approach risk, and how do you deal with it, and how do you deal with the unknown? And I wanted to say one thing about dose de-escalation. Well, I guess two things. One is that, there's patient advocacy groups out there that are trying to help answer this question too. So there's the rightdose.org, and that's a big organization led by medical oncologists in the field, including patients, to try to figure out, does everybody need maximal treatment? I think there's a lot of trials that are ongoing to try to figure that out. Can we de-escalate, like in the HER2 setting? And then I think it's also kind of important to realize how we came up with the dose, right? So it starts with kind of cells in a petri dish, and then it goes to like a mouse. And then there's like some calculator that the FDA has that converts the mouse dose to like a human dose. And so, how do we come up with this calculator? I don't know. Actually, don't put that on Instagram. Just, and so, so we, there's a calculator, and we try to make it as accurate as possible. And when we start a phase 1 clinical trial, we start with that dose, and it's called a dose escalation trial. Now they're kind of converting it into phase 1, phase 2. But really, originally, the plan is, you try to recruit a small group of people to take one level of that dose of drug, and then you just go up another level and recruit another small group of people to take that dose, and then you go up until until people can't tolerate it anymore. And then you just go back to the dose that they can tolerate. And so that's how they move that dose forward in other clinical trials. So I think once we understand kind of the history of how doses are selected, then it reframes, do we have to take it all the time, that maximal dose? And I think that kind of removes some of the fear when you have those conversations with your oncologist, is, do I have to tolerate every single one of these side effects, or can we think about something else? But those are conversations that you guys, have to have kind of personally and with your oncologist.
Thank you so much for that. I think that walkthrough of how these studies happen, how they move forward is so important. That context is really good for us to have as we hear about these studies, but to understand the difference between when something is still in the petri dish versus when it's in phase 1, phase 2, et cetera. If you don't mind indulging me, I'm going to go a little off script, but Elizabeth, Dina, Janie, you also all work with patients. What are the conversations that you have around quality of life? Dina and Janie, of course, we're not necessarily talking about anything physical, but the mental impacts of the information that we can learn through genetic testing is a lot. So what are those conversations like for you?
Yeah, well, so the reason the word counselor is in genetic counseling is because a lot of my job is addressing the psychosocial or emotional, or as Paige calls it, mushy, implications of either being positive or negative. And we actually, in my graduate training, have a whole course on, they call it breaking bad news, but it really is kind of framing it, helping people through it, understanding it. And I think that's really important when you're doing genetic testing or when you're given a diagnosis, to have a provider that really can take some of that time, can understand it, which is why events like this are so important, because we get to see the human side of everything that we're so used to seeing the clinical side of. So for me as a genetic counselor, one of the reasons I love my job is to be able to not just talk about the science, but about how it impacts that person sitting in front of me and their sister and their mom and their children. And, there's so many parts to that. So I guess, yeah, my conversations they're very individualized, but I definitely recommend seeing a genetic counselor if you're having any genetic testing, because you get that added counseling part as well.
Can we add something? I just want to say something on that note, thank you. When my genetic counselor told me, they called me, and I was at work, and I was young, I was 23, and she's like, you are positive for BRCA2. And I just didn't know how to react, and I started crying, and she's like, oh, are you crying?
Oh my God, I'm so sorry. And there's a right time and place to give news, right? And then there's also a right time in someone's life to do a test. So if you're about to get married, I'm like, let's wait a little bit, so because this can be life-changing news. So yeah, I'm sorry that you had that experience. We're not all like that.
I was just going to say that I think we're all different. Every person is different. Every patient is different. And what we are learning at Natera is that all breast cancers are different. So just because you have a triple negative and you have a triple negative, they're not the same. And so it is really important to, meet patients where they are. I have people say to me, there's anxiety around waiting for the results. And my sister had breast cancer and lung cancer. And I think back to her experience, and she had anxiety every day. It wasn't just waiting for a scan result or a test result. So, I just think meeting patients where they are and understanding who they are. And I think Eleonora said it great. What are their goals? What are they working for? And so I think that is vital.
Okay. So for me, I think that a lot of breast reconstruction is a conversation, and it's me listening to my patient's priorities. And that's going to be different for every patient that I meet. And I think of those conversations as really me taking the time to understand the patient in front of me and where they are in their life, what they want to get out of breast reconstruction, and it's different for everyone, right? So I think also just recognizing that the patient is the most important person in the room, and I'm there to serve, right? And that means that I don't show up saying, you need a deep flap, you need an implant, you need a flat closure. It's really saying, wait a minute, what's your timeline? What would make you feel good at this point in your life? I think it also saying, this isn't a decision you have to make forever right now. So, right? So you can decide, at the time of genetic testing to wait. And you can do that for as long as your clinical team and you think is a good idea. You can decide at the time of diagnosis that you don't want breast reconstruction. You can decide that there are other things going on in your life. And your team, your breast reconstruction team, should be as interested in you when they are not operating on you as they are when they are operating on you. Yeah. I think if you should use your intuition strongly with your breast reconstructive team. You know what it's like to be sold something. We all know what that's like in life. If you're getting that vibe, move on. This is your body and your life. We're here to serve, not to make money. Don't be sold a surgery because you have to live with that. I don't, right? You live with that result. So take your time. I think of my Previvor patients who maybe never heard, we can actually do a surgery for you where we save your nipple years ahead of time. We can do a breast lift. Say your nipple's low and you want your nipple to be saved and lifted. We can do that surgery months or years ahead of time, and you don't have to have a mastectomy. And I can get that covered by insurance because I'm persistent. That's not a cosmetic surgery. Right? So I just want to plant this idea of don't accept it. Don't accept it just because in your town of, Kingsville, Tennessee, the doctor is telling you that. We have the internet, and doctors like me are available to you to give you information, even if we're not operating on you, okay? So.
Thank you. I would love for us to just sit with that for a moment, because that is why we're here today, because you have options to find surgeons like Elizabeth. You have options to see providers like all of the people we have on stage, and we are so fortunate to be able to get this information and use this when we go back to our next appointment. So just gonna take a breather to say thank you, because that was really, really moving. And I think this is also a really great segue into the next question that I had for you, because we might not all be fortunate to have people like you on our care teams right now. So I would like to ask each of you, how have you seen patients successfully advocate for themselves in your practice?
I could start. Yeah, so I think when we were talking, when you were saying this, Elizabeth, it made me realize, and I talk about this a lot, that the doctor that you, or the medical team that you start with does not have to be who you continue with, right? When you're diagnosed, when you're diagnosed, typically, they say, okay, you had a breast biopsy, was abnormal, and here is your breast surgeon, and here's your medical oncologist, and here's radiation, and then all these other people on your care team, right, that really lift up what everyone else does. The social workers, the dietitians, the genetic counselors, and so forth, the nurses, and everyone. And that might, in the moment where you have to make this acute decision, that you kind of sometimes have no choice, because maybe you're in a place that doesn't have a lot of medical centers, insurance issues, but later when the dust settles, that may be the time. I always recommend second opinions, third opinions if you need them, but if you can't get it initially, it's okay to do it later. I see a lot of patients who come really for survivorship consultations and to talk about, all right, I'm done with chemo, I'm done with radiation, I'm on endocrine therapy, or I'm on immunotherapy or HER2 therapy, and can we talk about what life looks like going forward, what I should be doing, what I should be looking out for? So I think the best way, and there's so much great information online, there's also misinformation, so just putting that out there, but I think just being true partners in your care and not settling for something if it doesn't, what Elizabeth said, if it doesn't feel right, if someone's trying to sell you something, or you just don't walk away feeling heard, you have options, and there's so many other people. And I think there's a big push right now to change the laws about telehealth, because right now that's a big limitation, that you can only do telehealth in states where the physician is licensed. And that was waived during COVID, and now went back into effect. There's a big push to try to change that, because that would really open up options for so many people. Most visits can be done, at least in medical oncology, as a telehealth. So I'm hopeful that that will look a little different in the future.
Can I just interject? I think in the reconstructive surgery territory, because there are so few reconstructive surgeons, we're able to get around that. So I can do telehealth consults for patients around the country because the resource is limited. So I think that that's an important thing for you guys to know. If you're in Maine or Alaska, you can still reach out to a doctor in another state and have a telehealth conference.
That's good to know.
One of my kind of tips for anybody, and this isn't just for genetic testing, but for any type of laboratory tests or visits with the provider, if your insurance doesn't cover it, or if your doctor or team tells you it's not covered, but you really want it, a little hot tip is asking for the cash pay rate, which a lot of people don't realize, but a lot of these companies and a lot of clinics have cash pay rates for people whose insurance won't cover something. And so it tends to be pretty low, and in some cases there's financial aid to make it no cost. So like for genetic testing, I hear one of the biggest barriers is cost, and it should never be, because we can usually get it covered. And then that goes the same for different lab tests, and even seeing a provider maybe for a second opinion, they may have a cash pay rate. So don't ever let cost be a barrier to getting the care that you deserve.
That's great.
Yeah, I'll just echo that. I think what everyone has said here is that you should advocate for information, and I don't think anyone on stage or your own provider should ever be, sort of take that in a different way. I think like when we say you have options, you have options. You have options to get second opinion. You have options to get information for yourselves, and I think sometimes people shouldn't feel stuck if they're on one provider, or they're afraid that if they go somewhere else to get a second opinion, they'll lose care in their own home team. If that's the case, then that wasn't really that good of a team to begin with, Yeah. So I think you should feel free and empowered to seek out information in any way that you can, and then know that we're here to, at least I think all of us on stage are just here to serve.
That's great.
I don't think I can think of a thing to add to that, except I agree with all that. I was going to really hit on the financial assistance and the cash pay options. So, you know, you are the master of your body, and so know that in the end, it's your decision. So that's all I want to add.
Thank you for that. So, if you know anything about me, you know I love a theme. So, getting back to our theme of you have options, I'm going to go one by one. But starting with you, Janie, what is an option that you think more survivors should know about?
You know I'm going to say Signatera. You would be disappointed if I didn't. I was talking with a Breastie this morning, so if I can quote her, is that all right to quote a Breastie? So she was asking me about Signatera, and I said, think about the questions that you have asked and you have wondered about and you have sought out answers on the internet and from everyone you know is, after surgery, did you get it all? And how do I know my treatment's working? And to answer the question that she asked me, how do I know if my cancer's coming back? And so as I talked about Signatera to this Breastie, she said, oh, so another tool in my tool belt. And I said, absolutely. I think that's the best way to put it. It's another tool in your tool belt. I think that's the best way to describe it. You can't use it alone. You use it with all of the other tools that you have. Sure, I would be happy to.
I promise we did not plant her there.
Here's the quick answer. So we take tumor tissue, either from your biopsy, from your surgical specimen, or if you have a biopsy from a metastatic site, we can use any of those. We do whole exome sequencing, which is just a fancy term for how we look at it. We then do blood at the same time, because we want to filter out any noise. And we look for the 16 most clonal or truncal mutations that are driving your cancer's growth. From there, we develop a blood test. So moving forward, you just have a blood test, and we go, when your blood comes into the lab, we go get your test. So this isn't a panel. This is a test built on the mutations in your cancer. So, you know, I said everybody's different, everybody's cancer is different. So that's why. So that's Signatera in a nutshell. Please come by the table if you want to chat. We're going to be in Breastie Boulevard or whatever that building is today to chat about that. So. Yeah, so she asked if it was possible, if she had already had her surgery, and absolutely it is. We actually have gone and sought out tissue for patients that maybe had surgery 5, 8, 10 years ago. Yeah, so it's where you are in your journey, right? So you can start in the beginning, even in the neoadjuvant space. We'll meet you wherever you are.
We are going to have a Q&A time at the end, so I do ask that people hold their questions, and then we will come around with a microphone so everyone can hear your question. But please keep them in mind, because we would love to get to them afterwards. Eleonora, to you, I would love to ask for options for people impacted by gynecologic cancers.
I think that's a great question, because we talk so much about breast cancer, and and my patients say this to me too, as I treat both breast and GYN cancers, and a lot of the GYN cancer survivors, thrivers feel like there's so much focus on breast cancer. We're using immunotherapy now in cervical cancer. There's new drugs being tested in ovarian cancer. So there's a lot happening as well. There was just a study presented at ASCO about, do we need to take out all these lymph nodes for ovarian cancer surgery, because that results in lymphedema and swelling of the legs and a lot of discomfort. So there's a lot changing as well, but the same idea of you have options. We're not, not everyone is getting the same cookie cutter treatment as we were doing. Everyone got the same thing, and that's a lot of that is changing.
Thank you. I think that's really good to know that a lot of what we hear for breast still applies to our GYN breasties. Isaac, what are some options that people living with stage 4 disease should know about?
Yeah, I think just there's a lot of options, I guess, is as I'm trying to go through the list in my head. I would say that I'm very excited about this new class of drugs called antibody-drug conjugates. I think we're starting to see breast cancer treatment shift away from, categorizing breast cancer as specific subtypes of breast cancer, but moving towards a subtype-independent treatment. And I think that's a very exciting space because that means there's more drugs available to more people. The other space I'm really excited about are tumor vaccines. I think we're actively doing research in that area, but there's also very mature products that are coming. And I'm hoping that they'll be offered to, at least in trial form, to breast cancer patients as well. And I think those are options that I think are really revolutionizing, how we think about cancer and how we treat it. And then I think we touched about this a little bit, but I think, or a lot, but I think, asking, your provider about kind of testing of the tumor, testing of your blood. I think that is very informative if somebody has stage 4 disease, because what you're trying to do is just open up the treatment landscape for yourself. And the more that you might have certain, you might learn about the tumor having certain features, maybe genetic features, that actually just helps with more therapy options.
Over to you, Dina. What are options for testing beyond BRCA?
Yeah. So, a while back, Angelina Jolie really made BRCA, or BRCA, as people call it, really popular, right? But it's actually not the most common hereditary cancer syndrome. There's another syndrome called Lynch syndrome that is very, very common. Oh, I see. Yeah, so it's that is confers a very high risk for gynecological cancer and colon cancer and several other types of cancers. And most people that have it don't know they have it. So if you've only been tested for BRCA1 and 2, it is so imperative that you have a full panel, because there's also other breast cancer genes. There's a lot of gynecological genes. In fact, with ovarian cancer, the studies have found that up to 1 in 4 cases of ovarian cancer are caused by a hereditary cancer syndrome, which is huge. So that's why every ovarian cancer person with ovarian cancer should be offered a panel. So just knowing that, just BRCA1 and 2, I can't emphasize enough that that is not enough if that's all you've had testing. And it's very easy to get either update testing or get an expanded panel these days. So you can always come find me if you have questions about that.
I'm sure you're going to have people flocking to you afterwards.
I'm happy.
Elizabeth, what are some options that previvors should know about? I know you mentioned some before, but I know that you also have many more that you'd like to share.
Yeah, I love, again, the option that most previvors that I meet don't know about is the fact that we can do a breast lift ahead of time covered by insurance to save your nipples. So that's not an oncoplasty, it's not a mastectomy. That is a nipple sparing procedure, and it's something that should be covered by insurance. So I want previvors to know that, and I also want you to know that that really is protected under the Women's Health and Cancer Rights Act. So and I guess this applies, to previvors, survivors, thrivers, because breast reconstruction is protected specifically under that act, if your surgeon is asking you to pay cash or be out of network, hear this. It's because your surgeon doesn't want to accept the payment from insurance, period. Okay? There's no surgery out there that for breast reconstruction that isn't protected under that federal law unless it's experimental. So if you find yourself in this position where a surgeon says that's cosmetic if you want to do a lift ahead of time, no, it's not. It's just that your surgeon doesn't want to do the work to get it covered or accept the payment from insurance. So just arming yourself with that knowledge helps you find the person who cares enough about the work to, for me, take the payment from insurance And even if it's low, then advocate with insurance for a better payment, but not to turn away a woman because the payment is too low for me. Do you know what I'm saying? So there's nothing in breast reconstruction that you should be paying cash for unless you want to.
And does that include aesthetic flat closure? Because I know that we hear often from breasties that they can face pushback if that's what they are looking for.
Right, so aesthetic flat closure, so write this term down somewhere. There's something called adjacent tissue transfer. That is a way for a plastic surgeon to be paid for doing an aesthetic flat closure. That's the code that I can use to be paid for that surgery. There is not a code for aesthetic flat closure. And I have been in conversations with insurance companies who tell me that an aesthetic flat closure is part of a mastectomy. And it's not. It's not. It's completely different. You just have to have a plastic surgeon who's willing to have the conversation with the insurance company about what the surgery is, and to say, I will happily use your code that you already cover. It's 14301, 14302. That's the code, right? Happy to do it. Happy to do it, and I'll get paid, whatever it is. It's not part of a mastectomy, it's different. So yeah, I should write that down somewhere so you guys can reference that. Aesthetic flat closure, adjacent tissue transfer, and those codes. Yeah.
We will definitely ask you to write that down for us. So with the time we have left before we hop into our Q&A, I would love to do a quick little rapid fire. What is one question that a breastie here can take to the next appointment that they have with their provider? It could be about anything, but just one question that you think is really important for them to have in their toolbox.
I'm going to quote the breastie again that said to me this morning about the tools in their tool belt. So I think my question would be, have we talked about or have we utilized all of the tools in the tool belt for me?
That's good.
I would say a good question to ask no matter where you are in your journey is, what health conditions am I at risk for in the future, and how can I screen or be proactive? I talk all the time about being proactive instead of reactive.
I guess one question that I might take is, can we have a conversation about what my goals of care would be? Whether that's, in the survivor stage or whether that's in, an advanced stage. I think those are all just very good conversations and philosophies to have.
That's great. Yeah, I agree with all of that. So I guess I'll just get pretty specific. I think just asking if your genetic testing is up to date. And then the other thing to ask too is, what does this mean for my relatives? Because even if you had a negative genetic test, if you had a cancer early, your relatives may qualify for covered screening. So that's something not everyone thinks about, but just understanding what your family members how they can benefit as well. Yeah.
So my question is one that's, I think, a good one to suss out who you're dealing with in reconstructive surgery. So it's, if you're not an expert in a surgery that I'm interested in, who specifically are you going to refer me to? Right? Yeah. So, okay. And this is one I tell patients a lot, and family members and friends. And it's not a rude question, and if someone takes it as rude, then you're in the wrong seat, right? If you are not an expert in a surgery that I am interested in, who specifically are you going to refer me to? Okay? And I think you guys pressing in that way is going to make my profession better.
Can we just get a huge, huge round of applause for our panel? Aren't we so lucky to have these experts with us? So I am really excited to give you all the opportunity to ask some questions. We are going to have some people running around with microphones, so if you have a question, please raise your hand. I see many. We're going to start over there since you had one before, but before we dive into the questions, just a little reminder that while we have these amazing medical professionals here, your care team knows you and your specific case best, so I really recommend keep your questions general, and then take this information back, bring it to your care team, and then of course you can come and talk to all these lovely folks afterwards if you have anything more specific. So let's get started over here.
Okay, my name is Claudia, and I'm just gonna give you a little background. In 2018, I was diagnosed with triple-negative metastatic breast cancer. And in 2021, I was again diagnosed with triple-negative stage 3 breast cancer. And immediately when I was diagnosed the second time, I reached out to all my metastatic friends, and they told me that I should ask my oncologist for genomic testing. And gladly that was done, and I was in immunotherapy for a year. Now, my question is, when I talk to many of my metastatic breast cancer friends, they don't even know what genomic testing is. Why? Is it because we as patients are not aware of it, that we don't advocate for ourselves, or is it because the oncologists don't know about it? So that's what my question would be. Who is, or how we can make sure that everybody with metastatic breast cancer knows that there's genomic testing available?
Who would like to take this? Do you want, Eleonora?
I think that's a great question, and I think there's two parts to it. One, I will tell you that, I think it is often being done, but if there's no actionable mutation, sometimes it's just kind of said, okay, it's done. And like in the vocabulary and in the language of everything that's happening, sometimes it's done. Because I will have patients who ask about it, and we did it 6 months ago or a year ago, but there was so much else happening. So I think that's part of it. I think another part is people being in this room and sharing and educating others, and that's the power of this community, that someone said to you, did you have genetic testing or genomic testing, and you can share it. And I will say, yes, it's still not being done. I was on a panel recently and was talking to a pharmaceutical company that was saying that, yes, a lot of it's still not being done. So that's where the education has to come to the oncologist. And a lot of it, if you're practicing, if you're doing multiple disease types, it's a lot. So I think it's multi-pronged, and it's really important for everyone here as a patient to advocate for themselves. I think the days of your oncologist tells you, you have to do A, B, C, and D, and that's it, are over. And it's okay to have a conversation. It's okay to say, hey, can we talk about this? Like Jane said, what are the tools in my tool belt? So I think it's going to take all of us advocating together to get everyone the testing that they need.
Okay. I have two very quick questions. The first one goes to the right dosage and de-escalating. And I'm on tamoxifen, and I don't understand why I have the 20 milligram dose the same as everybody else of different sort of tumor profile, weight, and no one's been able to answer that. If that's like, why is that the protocol? That's my first question.
Yeah, so I guess some of it is, because a lot of the times it's the best evidence that we have. And so that's, and that comes from people running large trials and picking that dose, and then a majority of people in that trial responded to that dose. And I think these are the conversations that you should have with your physician, because I think when we prescribe that dose, it's based on that trial, but when we go outside of that, we don't know what the outcome will be. And we don't really know what the outcome will be in general, because each person is different, and they're not, defined by that clinical trial. But I think there's certainly an increased sense of unknown. And I think that's the conversation that you need to have.
Okay. Super quickly, Dr. Potter, I've gotten conflicting information on whether or not to do breast massage post-reconstruction and for how long.
I think that's a great question, and I think it depends on the type of reconstruction and what your specific issues are. I love lymphatic massage postoperatively. We have a lymphatic therapist in our office, and we start that massage pretty quickly if patients want to do that. But I think that if you have an implant reconstruction, sometimes that can create malposition or can move the implant to a place where you don't want it if you do it too early. So there are ways to do massage that's gentle away from scars. I think that that's really a very specific question for your specific case that your team should address. So if you have a high risk of capsular contracture with an implant, say a radiated implant, or you've had a capsular contracture already, the approach may be different. If you have had an implant malposition, the approach may be different. So it's actually good that there's not one set answer to that question, because there's not one type of reconstruction that demands a specific protocol, you know? Does that make sense? Okay.
Hi, my question is for the next generation of previvors. I thought I was going to be a previvor. I found out when I was 26 I had the BRCA2 mutation, but then I got cancer like 10 years earlier than anyone else in my family had. And so for me, it's about like anxiety about my daughter and when to talk to her about it. I'm a really open person, so part of me thinks that, you know, as we wait to know, I just assume she has it, and there's a chance she didn't. So part of me wants to know just so I might not have to go through her whole life knowing that she has it. I might be relieved. But I'm just curious what your perspectives are on when, not just to talk about it, but when to actually test or support testing to like ensure more previvorship.
Yeah, definitely. So your daughter is how old?
Really young.
Really young. Okay, yeah.
Like I wanted to know like when she was born.
Yeah.
She's 9. I'm not going there yet. But
this is a really common topic of conversation that I have with patients. So the way we kind of think of it is typically with BRCA and many of these hereditary cancer syndromes, it doesn't change the care of children, right? So there's nothing really in the vast majority of cases that would change at all. And so knowing that nothing is going to come up now, we do recommend waiting till a child is mature enough that they can make the decision for themselves, which typically we think of as 18. There's always exceptions. I've seen really mature 16-year-olds who want to know, but part of my job is making sure the child wants to know and that it's not the parent, right? Because they're their own person who should make their own decision about that. And I know that that can be really difficult for the parent to just have that in the back of your mind, but just reminding you that there is nothing that's going to come up, you know, between now and when your child is a teenager. And it's really hard, but, you know, it's a good conversation to have on an ongoing basis if you have a therapist that you talk to or anything, but just knowing that there's nothing to worry about right this minute. I don't know if that helps.
Hi, I'm going to get a little closer. My name is Cheyenne. I'm going to start by prefacing a little bit of information about me and my diagnosis. I'm a sonographer, which is an ultrasound tech, and I graduated in 2020. Within a year, I found a mass within my breast. I scanned it myself. It looked highly suspicious on imaging, so I went and got a professional, you know, someone else doing, and it came back as BI-RADS4 biopsy. Went to a surgical onc. They said, oh, this isn't cancer, come back in 6 months. And luckily I work in the force, so I said no, I went somewhere else, got a second opinion. It was stage 2, grade 2. When it comes to imaging, imaging is kind of your first line to diagnosis, I think. Definitely genetic testing too. What are we doing, or what new imaging, I guess, testing earlier, or other things that we can do to help find cancer, that way it's caught sooner? Is there anything that y'all are aware of within the imaging community or imaging, you know, area that may help diagnose or treat patients sooner? Is there anything emerging?
I mean, I think there's a lot happening. You know, there's a lot of research into better techniques, you know, and figuring out, like, contrast enhanced mammography is becoming more popular, more studies are being done with that. how AI will fit into better detection. Who needs to be screened? I mean, the age is changing. There's actually a really interesting study ongoing that anyone can enroll in called the Wisdom Study that's really looking at, I think, starting at age 30, I believe, do we just screen, following 40 and every year, or based on our personal and family risk, can we start earlier with different modalities? So there's a lot happening in that individualized, there was a study published a few years ago that basically said that for Black women, starting at age 40 is a huge disservice, and we really should be starting in our early 30s. The problem is that insurance and the big organizations that set the guidelines are not catching up to that. And that's why we have to continue to push and continue to advocate. And this is why people should be getting a breast cancer risk assessment starting at the age of 25 and periodically thereafter. And that means not your doctor saying, oh, you don't have a family history, right? But that means the detail, the going through, the models that exist to really quantify risk. Now, they're not great models because I'm sure people in this room have done it and were diagnosed with breast cancer and told they had a 2% risk. And I think that's where the polygenic risk scores and the research being done into that is going to be really a game changer as well.
On the research front, I'll just add that there's kind of like PET scans, but there's new dyes that can go after kind of molecular specific features on cancer that can be tracked throughout someone's body. And so that's a really exciting space to keep an eye on.
And I also just want to plug that we will have an interview coming up on the Peak with two wonderful breast radiologists who will share about a bunch of new stuff coming up in breast radiology, so that's exciting, so keep an eye out for that. Alex.
Hi. I first want to say thank you to everyone for taking the time out of your busy schedules to be here and your patient-centric approach to care. I think I speak for myself and many people in this room who have had experiences with care providers who don't share that passion, and I really appreciate it. So to that end, what resources exist for you guys to share that with your peers, like peer-to-peer, the importance of what you do? I'm very curious about that.
Well, I use a lot of social media. I mean, that's like probably a lot of us do. And I think that putting the patient up front, thank you. Putting the patient up front on social media, putting the type of care that we provide in front of more healthcare professional eyes, and really like humanizing healthcare, I think is a way to create that visibility that, like you said, you're taking videos to your lab so they understand what they're doing. And I think the more we connect and the more we can connect other providers with like you guys, the more maybe patient-centric, hopefully, things will be.
Yeah, I love this question. You're getting to the heart of kind of disrupting the current delivery system of care. I think that so many meetings that doctors attend are doctors talking to doctors about patients. And we're starting to hear from patients and talk to patients about patients. So what I've done, again, social media, I think thinking about patient advocates, putting the patient first, telling patient stories, making sure that other doctors, making that apparent to my colleagues, right? This is what I'm doing, applying positive peer pressure. I take insurance, why don't you? Right? Like, oh, it's you can get paid for that. Just being open and honest about that and disrupting the pattern is helping.
Yeah, I think like, I don't want to interrupt applause. I don't want to interrupt applause.
No.
I think, one thing is part of what we can do is also normalize involving patients into decision-making, into even research. So, one of the things that I did, which I think is revolutionary, but I'm hoping it won't be so perceived as out of the ordinary, is I involve patients and patient advocates in my research lab. They attend my lab meetings, and the revolutionary part was, I think I was able to form a friendship with patient advocates, the founders of GRASP Cancer, and we decided, if I'm going to start a lab, why don't we all start a lab together? And then that really puts at the founding of a research that we do centered around who we're trying to serve. And so I think that's the type of normalization which seems very foreign when we go to these conferences. You know, but I think it really is something that we need to say there's value here. There's value in these partnerships, there's value in these conversations. Even though the science, you know, maybe not everyone is getting the science 100% of the time, but then we need to do better at communicating it so that everybody can access it.
Yeah, I just have to say I'm a Chan fan. Like, right, I just met Dr. Chan, but we need for his lab to be supported. So someone out there somewhere has access to somebody who can help support what he is doing. That is profound. So huge props.
Can I just add one thing? Don't underestimate this group and this platform that you have in this group. I remember meeting these 4 ladies a couple years ago and them talking about their plans. And I was almost blown away when I walked in today and saw this room full of breasties. I'm like, you have a great platform, don't underestimate it.
Hello, good afternoon. I'm Oksana. I have 2 questions. The first one is that I recently became aware of a new term in the cancer community, which is oligometastatic. And I was wondering if the oncologists on the stage could talk about what oligometastatic is in the stage 4 world and what different treatment options are available for a thriver who is oligometastatic compared to one who is not oligometastatic.
Yeah, so I think that's actually something that, you know, one, my research is focused on, but also 2, I think we're trying to explore, you know, whether or not if somebody has just one, you know, metastatic site and what options that we can do. So I think one of the things that when we're thinking about treating metastatic disease is that we'll often switch treatments when we see, you know, a lesion pop up or we see progressive disease, and that's the term that I think everybody is really afraid of. And I think we don't often stop to think maybe we can control that one site, whether we can do different options like radiation therapy. We're developing therapies in our own lab that can actually just treat that one site, that one organ, and then you know, progress with the regular therapy that did such a good job in everywhere else in the body. And I think that's where, you know, you want to have a conversation with your provider to say, is there different ways we can think creatively about this particular situation that we find ourselves in? Sometimes surgical options are there. I think it's just, you know, I think there's just conversations and it's kind of underexplored, so that's why people aren't so willing to think about it. You know, I'll just put one more put it out there. You know, we're trying to do our own research into saying how effective are chemotherapies at specific sites of metastases, or how effective are current therapies on specific sites of metastasis, because I think that's where we'll be able to find value in the current time, and then, you know, with hope for future research catching up. Oh, it's when you have one lesion pop up in one organ, and you don't have it, you know, elsewhere in the body, so it's not widely metastatic.
Thank you. We just have time for one last question. I'm sorry, I see so many hands up that have been up for a while, but please know our experts are here to answer your question afterwards. Many of them have their own breakout sessions, so you will have time to get your questions answered, but we will go over here.
Hi, my name is Shella. I just wanted to kind of talk about my experience. So I was originally diagnosed in 2019 with an estrogen-positive breast cancer on my left side. It had gone to my lymph nodes. I also have RAD51D mutation. My younger sister as well has that. So I did, I think, about 12 rounds of chemo, radiation, the surgery, and then I was premenopausal, so I was getting the shots, the Lupron shots here as well. I think 6 months into it, I started developing really bad headaches. It was every morning. I told them, I reached out to my team, I said, every morning I'm waking up with a pounding headache, and it's just like right here. And they were like, oh, it's maybe the chemo, it's this, you know. And then when I told them I started vomiting on my way to work, they were like, okay, we need you to come in. They take an MRI, they find over 13 tumors in my brain. So also they checked my chest wall lymph nodes. They were also here as well. So they took a biopsy, and then it had switched over to triple negative breast cancer at this point. So I've been on carboplatin for about 3 years straight, and I've had 6 reoccurrences in my brain. I've had a craniotomy. I've had over 13 radiations to my brain. And my head hurts every day in the afternoon now. I've told them, so I have an MRI on Monday, I have chemo Thursday. I am like at the end of it at this point. Like, I'm so overwhelmed with it because the last treatment I went to, they're telling me I need to go back to 3 weeks with carboplatin. Maybe this is why it's causing the reoccurrences. But I just so frustrated because every time I do an MRI, which is every 90 days, they find a new lesion. And I just don't know what to do because I asked, is the carboplatin going to the brain? Some say yes, some say no. I'm just so at the end of it at this point, and I can't even imagine going back into the hospital next week because I'm so frustrated at this point. So I just want to know what I should do next because I feel like at the end of it at this point.
Thank you for sharing with us. You have all the breasties here at camp sending so much love and loving on you. But I will turn it over to our experts here. Do you have any advice?
I mean, so I'm actually happy to talk to you afterwards about it.
Thank you.
I think that's, I'm happy to. And then I think, just as a general kind of what I'll probably be sharing is, I think these are times where clinical trials might be very effective, and people should be talking about that.
They don't mention any of that. They just now they're like, oh, we scheduled you for every 3 weeks. I'm like, I'm not showing up. I can't promise you because I need to live my life. I need to work. We have bills. Like even if I'm sick, my life doesn't stop. I need to keep the insurance. So I'm like, how am I going to make this work for myself? And I asked the doctor, so this reoccurrence is how aggressive is this cancer? They're like, it's not really a reoccurrence, but it's a lesion. I don't know. I just feel like a lot of questions are not being answered, and I'm actually gonna switch over doctors because I haven't seen my oncologist since January. I just see the nurse practitioner, so it just doesn't make any sense.
Yeah, I'll just say one other thing of advice for everyone is that you also want to find yourself in situations where if you do, need to reach out for these clinical trials, you want to seek second opinions because you want to find people who have a large network that can plug you in and get you into, clinical trials, whether it's locally or even nationally, and just being aware of the trial landscape. Because we all kind of work together to help move, patients to where they might need to go for particular trials that might be beneficial to them.
Thank you so much for sharing. Definitely, please come see Isaac afterwards. Thank you all for sitting with us, for asking your great questions, and thank you so much, Elizabeth, Dina, Isaac, Ellen, Janie. We are so grateful for you all. And now we have so much more to do. Come see these folks. Go enjoy your next activities. Love you all so much. Thank you.
I'll just grab a photo.